to our latest webinar. My name is Les Jones. I'm joined by my colleague, our clinical lead, Rebecca Dunstall. Rebecca will introduce herself shortly. The topic of today's webinar is the developing personal care plans. It's going to take the format of a PowerPoint presentation and a little bit of a hands-on demonstration to illustrate some of the points that Rebecca will make as part of her PowerPoint. Do you want to?
Yeah. Thank you.
Send Rebecca off to start her PowerPoint. Just a little bit of housekeeping. As I said, cameras and mics, if you could make sure that they stay switched off. My colleague Kim is manning the chat feature. If you have any queries or questions, please feel free to post them on chat. We'll try and pick them up at the end of the presentation. Kim will also post various links to some subject matter that we discuss as part of the presentation. So I'll just pass you across to Rebecca, and I shall see you in about half an hour.
Thank you, Les. Good morning, everyone. So welcome to our webinar today, Developing Personalised Care Plans, where we hopefully are going to important it is not just to, of course, do the assessment and prescription, but to then follow that up with making sure that we are putting comprehensive, clear care plans in place. As clinicians, we obviously can't be there 24/7. So when we provide that piece of equipment and we leave that environment, we want to make sure that everyone using the chair, whether that's the individual themselves or whether we're relying on the support network, but everyone who has access to that chair and has a responsibility to use that chair knows how to do that competently, but also confidently as well, making sure that they have a clear guide on how to use it safely and appropriately, but then also risk factors and things to look out for with contact details on how to reach out to us should they need further support. So we're hopefully going to just, first of all, just quickly review the importance of holistic postural care. That's always a good place to start. It's always a great message to start with to raise that awareness. We'll discuss then the impact of thorough care planning and understand the critical role of compliance with that care plan and how we can hopefully enable that. So postural care then, it's essentially the holistic use of any technique that we use to minimise postural abnormality whilst also enhancing functional movement. And it's an approach that aims to preserve, but hopefully even restore body shape for individuals who present with movement difficulties. Now, despite popular beliefs, body distortion is not inevitable. Even with individuals that we work with who have the most complex presentations, body distortion is not inevitable. With the right equipment, given in a timely manner, so being proactive with that approach, and the right positioning techniques, we can help to protect their body shape. Now, I know we are focusing on specialist seating today, but we have to emphasise the importance of that full 24-hour approach to postural care. The chair will only be as good as the other equipment that's used throughout the day and night, and how we integrate that together. What we need to do, of course, is address all those body segments and consider all those positions that a person will adopt throughout the day and night, which will involve that 24-hour programme. So we'll have the provision of seating, of course, the positioning equipment to support in lying. This will include the movement and handling techniques, so how they transfer into and out of equipment, but then also the advice and training for the support network as well. So understanding if there's any issues around competencies, whether we need to invest in some training. And again, that's something the CareFlex can help with, and Les will chat about that later through how CareFlex can support you with that. For successful specialist seating and any kind of postural care, we have to have this holistic approach. It's all about better understanding expectations, better understanding the needs of the individual and the support network, and understanding what daily life is for them and how we get that compliance with our postural care plans. Now, when we use the term holistic, it's a favourite word of ours, especially Les. Those of you who attend our webinars will no doubt hear us use this word. But this is about the treatment of the whole person, take into account the mental, the social, the physical factors, rather than just the symptoms of a disease. So this person-centred care, or client-centred care, which is what it used to be called, but person-centred care, patient-centred care, terminology that was used to be used as well. Not a narrow focus on the diagnosis. Of course, it can help us to understand maybe the prognosis, rehab potential, and so on. But it's also about the consideration of the person sat in front of us, their well-being and their expectations. So if we determine that key information on the individual and the support network, then we can ensure correct, safe, and consistent compliance. Individuals and caregivers, research has shown that they report higher levels of satisfaction when care plans consider their physical, their psychological, and their social needs in an integrated way. So this will be vital for the provision of the most appropriate management plan that can be confidently and consistently implemented. A collaborative approach will help to reduce the risk of postural deformities, and ultimately why we do what we do, improve quality of life for the individual. We obviously have the multidisciplinary team that hopefully you have access to and you can lean on for support and have that interdisciplinary working. But then we also, of course, have the individual at the centre. The individual should be involved throughout the assessment, the selection, the issue and review, but also the support network as well, especially if we're working with individuals with complex needs, where we might heavily rely on the support network, whether that's family members, carers, professional carers within care home settings. If we are relying on them, again, we have to consider their expectations as well, and how we aim to reduce dependency and carer effort to ultimately ensure safety. If we can understand daily life and ensure that the equipment is compatible with that, even down to things like hobbies and activities, and making sure that the chair, for example, enables that, then we will ultimately get compliance with a care plan, and then we will achieve our clinical objectives. And a key part of this, of course, is assessment. We've got the subjective assessment, so the information gathering part, where, as I said, we try and understand things like their expectations and goals, the history of their presenting condition, or any relevant past medical history, understanding their social history, so that's about the support network, where they reside, who we might be relying on to follow care plans, understanding their cognitive function and their communication. Can they follow care plans independently? Do we need accessible information? Do we need to liaise with speech and language therapy to look at communication? Capacity issues, whether we need to look at best interest decisions or guardianship up in Scotland. We'll understand about their function, their hobbies, their occupation, and this will give us a really good idea of what we need the chair to do within daily life for them to make them compliant with that. Moving and handling, essentially how they get into and out of the chair. Current equipment, but also any considerations or contraindications that we need to be mindful of as well. Things like, is there a history of pressure injuries? Are there behaviours that challenge that we need to be mindful of, especially when we talk about positioning within the chair? Do we need to be mindful of anything like swallow dysfunction, history of choking incidents, aspirations, and so on? And then we have the objective assessment, which is the physical assessment. And this is really going to be in two separate parts, because it's something we always reiterate within our webinars, is that we have the postural assessment, which as clinicians, we have expectations to follow out. So doing this postural assessment, and again, depending on the individual, this could be a full body postural assessment that could take you 2 or 3 hours to do within a postural management clinic. And And we gather that problem list, looking at their presenting sitting posture, their habitual preferred postures, and then getting them out into supine lying to see how close to that anatomical position we can get. What are the limitations on the body segments? What can we correct? What do we need to accommodate? The critical angles, especially for sitting, when we think about hip range of movement, knee range of movement, hamstrings, muscles, length. What are their postural support needs? Because as we know, we need that trunk alignment. We need to be upright to reduce the risk of health decline, because if somebody's unable to remain that upright symmetrical position, then there is a direct impact on their physiological function and of course their health and well-being. So what kind of support do they need at the trunk with their sitting balance, with their head position? Outcome measures are really key here as well. So we've got these objective measurements to be able to have a baseline so that when we do our review, we can compare it to make sure the chair is working as it is intended. But then also their sensory system as well, involuntary movements, muscle tone, what kind of sensitivities they have. Do they not respond very well to soft touch at the feet? Do they need more deep pressure? And so on. But it's really important here to highlight that this is something that we do as clinicians, and we need to find out this problem list before we then come to the seating assessment with the chair manufacturer. So again, Les can go in a bit more detail about what CareFlex can offer, but there's an expectation there that we come up with our problem list, we understand the postural challenges, and we come to the seating assessment armed with that information so that we can work collaboratively with the seating assessor to come up with those solutions together. So I just wanted to highlight that. So once we do our assessment, then we can look at making sure we have this effective seating provision. And the key bits here then are really making sure the chair is set up for the individual. So things like the basic dimensions of the chair can often be overlooked, especially in multi-user environments as well, when actually it's that first important step. The devil's in the detail, really, making sure that with the seat depth, seat width, seat height, and the armrest height is all set up for the individual's body shape and size. Because if it's not, we can cause more harm than good. For example, I have full range of movement. I don't have any pelvic instability. But if I was to sit in a chair where the seat depth is too long for me, it's going to pull me into that sacral sit-in just so I can flex my knees over the edge of the chair. And suddenly I've caused this significant postural challenge just because of the simple setup of the chair. Then we'd have a look at the personalised seating solutions. Are there any additions that we need to the chair? Thinking about the functions and accessories, positioning aids, head support, and so on to really personalise and tailor the chair to the individual. And then, of course, safe and appropriate use. So there are certain functions that we have to be really mindful of when it comes to specialist seating in particular. Things like back angle recline and tilt in space are not suitable or safe for everyone. We have specific leaflets and information on this. If you're new to seating, if you are maybe not understanding what the difference is between back angle recline and tilt in space, then we have leaflets. Again, use the chat function, and I'm sure Kim can make a note of that and we can send it out with copies of the presentation just to understand when we can use tilt in space and back angle recline, when we shouldn't use it. Because it's all about that safe and appropriate use when we leave that environment, that the support network and the individual know that clearly as well. And when we look at seating provision at CareFlex, we follow these 6 key principles of seating. So again, our provision and our care plan needs to reflect that, to make sure that we are comprehensive and holistic with that approach to ultimately, again, achieve our clinical objectives. Now, comfort, this is a top priority for us at CareFlex, because being comfortable and feelings of safety within the chair are key to increasing tolerance and maximising compliance. So research has shown that if a user isn't comfortable, they simply won't use that piece of equipment. So we definitely won't achieve our clinical objectives. So comfort, now this is a top priority for us. We of course have postural care, so making sure that we address all those body segments. Foundation for sitting is obviously the pelvis. It's at the core. It dictates what happens above and below. So we need to make sure we get that pelvic stability first, and then we work our way then through the body segments down to the feet and up to the head. That postural stability is key for function. So we need that proximal stability to get distal control. So to be able to remove the upper limbs from their low bearing role. So people are not clinging onto the arms of the chair, for example, and they're able to reach outside their base of support and engage in activities and tasks. So the pelvis is the foundation there, but we still need to target all those body segments, even the feet. We take 19% of our body weight through our feet, even in sitting. So we need to make sure that we get that stability and get that proprioceptive feedback through the feet as well. This obviously helps with postural care and function and independence, one of the other key principles there. But it also helps to encourage more normal movement patterns as well. So if somebody is experiencing involuntary movements or tonal issues or reflexes, we can hopefully try and dampen down some of those movements and normalize movement patterns by getting that pelvic stability. When I say about function and independence, this is of course important for things like hobbies and occupation and activities. When we think about their participation in daily life, it's also really important to protect the body structure as well. So if we can encourage stability, if we can encourage movement at the upper limbs, for example, reaching outside of the base of support, taking the joint through a range of movement, we're also encouraging blood flow as well to hopefully reduce the risk of injury, but also reduce the risk of significant secondary complications like contractures. We've got pressure management, of course. Posture and pressure are inextricably linked. The way we hold ourselves, the way we position our body segments has a direct impact on the pressure going through specific body sites. There are particular areas, especially in sitting, that are more prone, that are higher risk. Tends to be bony prominences, things like the ischial tuberosities, the sacrum, the heels. So just be mindful of that when we do in the key principles of seating, that we are addressing their pressure care throughout the 24 hours as well. And the key thing for pressure care, I'm diverging here, but just to really reiterate that it's about a regular change of position. So it's about redistributing pressure as much as is possible throughout the day. So it's not about achieving one perfect position. It's about this regular change of position through good postures throughout the day. We've also got health and safety. So of course, making sure that individuals are safe within the chair. So if we're working with individuals who maybe have erratic movements or severe movements, maybe those with chorea, for example, making sure that they are safe within the chair. That could be down to the prescription, making sure that they have padded surfaces and elements to the chair to reduce the risk of injury, but also as well getting that postural stability within the chair to try and manage some of those abnormal movement patterns. But a key part of health and safety is also their health as well. So by managing somebody's posture, we can hopefully manage their physiological function, enhance things like respiration, opening up the shoulder girdle, helping digestion, and even things like cardiac efficiency as well, to keep them healthy and reduce the risk of things like severe infection, choking, and ultimately hospital admission, which will of course affect their outcomes. And then last of all, we have their well-being. So again, going back to that holistic approach, making sure that we are addressing the social aspects, they have that interaction. Individuals who don't have appropriate postural care, who are sadly maybe confined to their beds, to the four walls of their bedroom, are obviously going to be impacting things like their social interaction. Now, lonely and isolation is actually twice as harmful as obesity is. So quite staggering. Really, the research has shown this. We need to get people access in their environment, get them sitting out and being able to access the home, access different areas, and interacting with loved ones, with family, with friends. There are two other aspects I want to add to this. When we talk about care plans specifically, we've of course got those 6 major key principles for seating, but I wanted to really touch upon the environment here as well, because when we do in our care plans, we have to enable interaction with the environment, use the chair as a way of being able to get out of bed, get out of the 4 walls of the bedroom, and interact with the environment. To do this, we of course need to consider the position of the chair in relation to appliances or windows. So maybe individuals, a hobby of theirs is watching movies, so be mindful of where the chair is positioned in relation to the TV. Maybe some individuals, their favourite pastime is watching the birds. So again, we need to be thinking about how that relates to the window instead of the TV. And this is all part of that holistic assessment, understanding what's important to them throughout their daily life and what we need the chair to do. We need to think about space for utilising function. So tilting space, of course, increases the footprint of the chair. Recline increases that footprint as well. So we need to make sure there is safe space to enable that. And then manoeuvrability around the residence as well, thinking about doorways and obstacles, and really thinking about how the care plan will reflect safe use of the environment. Ergonomics, again, if we're relying on the support network, making sure that the chair is manoeuvrable for the individuals and the support network as well, and to make sure that we're reducing the risk of injury and making that as easy and simple as possible. And then that integration with other equipment as well, which really comes back to moving and handling, safe transfers into and out of the chair. But how do we integrate a chair with the equipment they already have, or equipment that they will be expected to have in the long term? Bit of a tip here as well when we're talking about other equipment, especially maybe with complex needs and postural care, where somebody might have nighttime positioning, they may have a wheelchair, they may have, of course, the alternative seating, the specialist seating, and how we integrate those pieces of equipment, because we don't want to replicate. We want to make sure that the postural objectives change depending on support surface as well, because remember, a key part is a regular change of position, taking the body segments through ranges of movement, to make sure that we're targeting all those areas and not becoming fixed in one position. So just be mindful of that, how we don't want to, the specialist seating, for example, we don't want to replicate exactly what the wheelchair does. We want a bit of maybe different freedom, a bit more comfort, a bit more flexibility within the specialist seating, to make sure that we are getting a regular change of position. So then once we've had all that information gathering, this is just a really basic template example of care plans. You may already have care plans that you utilise within your clinical practice, or maybe this is something new to you. We have worked with trusts and organisations and developed specific care plans for them. So if this is something that you need a bit of support with, then again, please just reach out to us, and it's something we can chat about. When I have done care plans in the past, I've done it from the perspective of the individual, just to make sure that it's person-centred and anyone who's reading that care plan is aware that it's the individual's care plan. It really kind of highlights that we do what we do because we're supporting the individual. The awareness should always be on them, and making sure that we're always keeping them at the centre of that. So this is why I always use this tense when I do the care plans. And I think it's just really keeps it person-centred. So what I'm going to do now is just run through all these different aspects. So initially we have the equipment information, of course, where we are really identifying the product, the piece of equipment. Things like the brand, the model, the serial number, all that identifying information, just so anyone who picks up the care plan knows exactly which piece of equipment care plan. a bit of clinical justification in there as well. And I think this is really important, especially if you're relying on support network, so that they understand and they have an awareness of how important that piece of equipment is, so that they hopefully become more compliant with it. And they consistently and confidently use it to help the individual. It's not just a case of, that physio put this care plan in place and expecting us to do this. There's actually a reason behind that, and it's a really important reason for the individual's quality of life. And it's just that reminder, really bringing it back to that person-centered care, and understanding how it addresses their postural care needs, and gives any indication of their functions and accessories, including things like positioning aids, and the disclaimers that would need to come with that, the risks associated with that, so that everyone knows exactly what piece of equipment is expected. Photographs are, if you're able to, photographs are a real key part of this, and the care plans that I've done in the past would not be successful without those images from different angles, close-ups where needed, because it's so much easier to replicate, especially when you're expecting support networks to position individuals, because that positioning within the chair is really key and critical to how successful the chair is. And as they say, a picture says 1,000 words, really. So if you can get photos laminated and a part of that care plan, then please do. There also needs to be a section there on transfers, and how individuals actually get into and out of the chair, what their method of transfer is. Maybe this is where some support might be needed if you have access to moving and handling advisors. They might have their own moving and handling profile that goes along with the care plan, depending on how complex it is. So just maybe some signposting there if you need support from your local moving and handling advisor to add that to the care plan. There needs to be a guide for appropriate initial positioning as well. Hints and tips, maybe things like use the tilting space before hoisting, so the gravity can help bring that pelvis down into the back of the chair. Maybe things like the leg rest, tacking the leg rest away if there's a negative angle leg rest there. If somebody's still doing standing transfers, for example, making sure that we flip up the foot plate and move that leg rest out of the way so they can get a good, safe foot position before going into that sitting. So just making it as clear and concise as possible, because as I said, that initial positioning is really key for that individual, to make sure that they are safe getting into and out of the chair. We then need to be clear about the duration and frequency of chair use, making sure that the maximum duration that's tolerated by the individual is clear. That might be dependent maybe on their pressure care need. Maybe they can only tolerate 20 minutes, half an hour at a time, because of their skin integrity. Or maybe it's an individual who actually can tolerate 3-4 hours sat in the chair for a period of time, because we are utilising things like tilting space to change their position whilst they're in the chair. Visual timetables might be indicated, especially if somebody, as part of their 24-hour postural care, maybe they have a specific 24-hour timetable that goes through, maybe from 8 till 10 they sat in the chair, from 10 till 12 they have a period back into the bed with their supine positioning equipment, and then they come back to their wheelchair for eating and drinking, because they can have a good upright position with head control. And we might need to be really clear with a visual timetable here, so just be mindful, you might need to add that to that care plan as well. And if somebody maybe has been confined to their bed for a period of time and it's a new piece of equipment, we need to be really mindful of that gentle increase to tolerance as well. So we're not going to go straight in with using a piece of equipment for 8 hours. There could be issues with things like postural hypertension, and maybe just their awareness, their proprioception as well, and not really being used to being sat upright for a period of time. So we might need to feed that into the review plan and making sure that we are doing more regular reviews so we can increase that tolerance gently. There needs to be a section on there about cleaning and maintenance, making sure that you follow the manufacturer's guidance. We might need to provide recommendations for cleaning and sterilising, especially in multi-user environments, or if there might be concerns with continence, body temperature regulation, where there's where there's profuse sweating. So just be mindful of that cleaning, and do we need to consider a servicing schedule as well, and how we highlight that, and whose responsibility is it to arrange those and get in contact. What I find, and I'll cover this in a bit shortly, is to have a key individual. That might be the individual if they're totally independent, or it could be a key family member or a key contact at the home, a senior member of staff or the manager who takes responsibility for that and getting them to sign this care plan, because people are a lot more willing to follow things if they know they've kind of signed their acceptance, their understanding and their compliance with that care plan. There has to be an element in the care plan around safety, making sure that anyone who picks up that care plan is aware of all the risk factors. For example, is there a history of choking, aspiration? Are there current pressure injuries we need to be mindful of? Are there some functions and accessories that could be contraindicated? Do we need to make it very clear that back angle recline should not be used because of their extensor spasm, in which case we can see their pelvic stability and that tone shoot through the roof. So do we need to lock that off? And also an element for a process for seeking support as well should be clear. So as the prescriber, making sure that we provide contact details, that we highlight different risk factors to look out for, and should they see this, should they see a red area, should there be an incident within the chair, does their behaviour change? Is this an indication of their discomfort within the chair? Have their needs changed because of a neurological event, or just due to the prognosis of their condition? How do they get in contact with someone? If I'm the prescriber, making sure that there's a contact number there for the team. Should I move on? Should the named clinician change? Making sure that there's just a number there for the particular team so they can access that support when needed. And then, of course, the review process as well. So once that special seating system has been provided and our care plan has been handed over, we need to agree on that review process as well, and that's going to be dependent on the individual. It's important that the individual is reviewed following that prescription, just to make sure that we continue meeting the objectives and the chair is actually working as is intended. And then, depending on the individual, especially more complex cases, as I said, we may need these more regular reviews, and that care plan should make it process clear, so that they know who to contact, because they shouldn't necessarily have to wait for that review to happen if something changes. It's important that we are proactive, coming back to that holistic approach, that we are proactive to any change in needs, because again, that chair could be causing more harm than good if it's not used as it is intended. Some outcomes that can be used alongside the care plan. So this is really about the individual or the support network continuing to gather information, kind of like this ongoing assessment, and we might want to put things like sleep chart, behaviour charts, visual analog scales if pain or spasticity is of concern, and really using these objective measures alongside the care plan, so that we have this baseline but also this regular review process as well. Photographs, again, really helpful here to compare, and we can look back at actually what the chair was originally doing, and are we still meeting those needs, and is it still working as intended? And as I mentioned, it's identifying that responsible individual to make sure that the care plan continues to be used confidently but competently, and that someone takes responsibility for that ongoing assessment, and making sure that they know that they can reach out to us as the clinicians at any point should there be any concerns. Not only will it benefit the individual to be proactive, but it actually will make our jobs easier as well, because we can kind of address those and nip things in the bud before they become significant secondary issues. So thinking about the individual, the caregiver, professional, and then that signed acknowledgement of confidence and competence. So I just wanted to really apply all this theory to a practical application and introduce you to Callum. So Callum is a 20-year-old gentleman who enjoys spending time with his family. He lives at home but attends college 5 days a week. He has spastic quadriplegic cerebral palsy and epilepsy. A wheelchair user, hoisted for all transfers, has access to a range of specialist equipment at home. But his seating has alternative seating. He just had his wheelchair hadn't been reviewed for some time. So CareFlex were involved and prescribed. We've done the assessment process, worked collaboratively with a clinician and prescribed and provided a Smart Seat Pro chair. And of course then worked with the clinician to make sure that when we all left our environment that the care plan was clear. And everyone involved in Callum's care, mainly the family at home, but were aware of any risk factors and knew to contact us at CareFlex or the named clinician should any issues arise with Callum or with the chair use. So I just really wanted to just show you, and you'll get copies of this when we send out the presentation, but really the type of care plan that went out with Callum and some of the things we really need to be really clear of and highlight before we leave that environment and before we step away and pass on that responsibility. So what we're looking at is things like the equipment information, of course, the first part we said. So we might be saying something like, I have been assessed by, and insert the name there and designation of the clinician, and prescribed a CareFlex Smart Seat Pro specialist chair to enable me to achieve my optimum sitting posture and to sit out comfortably to engage with family at home. So again, keeping that person centred so that anyone who picks up that care plan fully understands why that chair is important to Callum. This is important to me because I am at risk of postural deterioration and experience significant pain related to my spasticity. My posture has been assessed and the chair has been set up to meet my needs and measurements. Seat width at 400mm, and then when Les kind of shows you through the chairs, kind of these key facts and figures are really important because they can follow these guides, especially if maybe the chair is maybe disassembled for cleaning or maybe something is removed for repair, that we know then how to set that chair back up for Callum. To ensure the optimum position in the chair, my pelvis should be positioned right back in the chair, my trunk should be upright and aligned as much as possible, and my feet evenly supported on the footrest. I have a head support for use at all times and a tray for activities. Please see photographs for further reference. So again, putting those photographs in really key, especially for maybe more complex setups of the chair. The chair has integrated pressure management, so I do not need an additional pressure redistribution cushion. If any red areas develop, reduce my time sat out in the chair and monitor my skin. If you are still concerned about my pressure care, contact the learning disability nurse at the integrated learning disability team. So again, given that information, things, the risk factors to look out for, and then how to contact someone and reach out for support immediately if there are any concerns, and of course putting the number in there to make that clear. I transfer in and out of the chair via hoisting with assistance of two using the overhead hoist in my bedroom. My sling must be removed gently after every transfer to reduce the risk of pressure injuries. It is recommended that I sit out in the chair for a maximum of 3 hours at a time. I can be transferred back to bed for rest or to my wheelchair if I'm going out and about. I will become distressed when uncomfortable, and I communicate this through facial expressions. So again, given as much information as possible about Callum, about how Callum would communicate if anything changed about his attitude towards the chair, if any of his needs changed. And again, this is about the holistic assessment. What does Callum usually do if he's uncomfortable or unhappy? How does he communicate this and making that clear within the care plan? The cleaning and maintenance section that I mentioned, so providing the manufacturer's instructions might be needed with the care plan, providing the user guide with the care plan as well, and having that in this nice, neat, comprehensive little pack. Please follow the manufacturer's instructions for proper cleaning. The chair can be disassembled for thorough consideration of infection prevention and control. If you have any concerns or wish to discuss the servicing schedule, please contact the local equipment store if that's where it came from. Obviously, it's different if it's private, if it's purchased privately, sorry. And again, you might need to put in the manufacturer details there, quoting the serial number on the sticker at the back of the chair. And again, that's something Les can show you as well, especially with CareFlex chairs. That serial number is key. And then we have the safety aspect. To maintain my safety at all times, please follow the user guide carefully. Please do not change the back angle recliners. This will affect my stability. Please do not raise the elevator leg rest, as I do not have the range at my knees and it will hurt. So always bringing it back to Callum so people know how important it is to Callum for his quality of life. You should not alter any aspect of the chair apart from the tilting space function up to 25 degrees. I am to remain upright for 30 minutes after food. Again, you might need a bit of MDT working here to understand what his needs are around eating and drinking, working with physios, OT, speech and language therapy. If I show signs of discomfort or distress, reposition me. If this is unsuccessful, transfer me back to my bed or wheelchair and seek support from the integrated learning disability team. If you have any concerns about me using this chair, make a record of the concerns and liaise with the integrated learning disability team. Please use the behaviour chart. It could be sleep charts, it could be visual analog skills, as I said, whatever goes alongside and whatever is relevant to that individual, to allow the gathering of important information around chair use. And then, of course, making sure it's signed by individuals. You've got those named people who are responsible for taking control of that care plan when we leave that environment. Putting contact details in, contact numbers where possible, so that we can continue to be proactive. Again, we're going to send this out, and obviously that's just an example, a template. It needs to be completely tailored to the individual, but that's something we can support with. If you're having a chair from CareFlex provided, then we are here to support you with that. Okay, let's get us back on screen so you can see, actually apply that then to when we talk about some of these facts and figures, when we talk about some of these functions, how the chair can help with that care plan.
Okay, so you're going to look at the chair that we supplied for Callum to try and illustrate the points made by Rebecca in her presentation. If I just give you a quick overview of the chair, I'm not going to go into a lot of detail. I just want to show you how we can help you with your input into the care plan to record the initial setup of the chair for Callum. So just an overview of the chair. It's a tilted space chair with back angle recline control at the rear of the chair. Now, what I'm doing now, this little segment of the presentation forms part of the training of the setup, so that the carers fully understand how the chair works, and I'll cover key points that may or may not be required. Chair has an elevating leg rest.
And these are all the functions to be mindful of when we talk about safe and appropriate use, making sure in the care plan, when Les showed you then back angle recline, tilt in space and leg rest elevation, putting in the care plan, are these safe to use? And if they are, how much can we use of them, giving angles, giving objective measurements for that?
So it's a 4-section multi-adjustable back. You've got pressure care, seat cushion, you've got seat width adjustment and seat depth adjustment. So if Rebecca helps me out with Callum's details.
Yeah, so when we said obviously about Callum, because of the knee contractures, elevating leg rest is not going to be suitable for him. So making it clear in the care plan that we set that up and we do not alter leg rest elevation, because all we do is cause pain, significant pain, but we'll then just pull him down into that sacral sitting. So making it clear about leg rest elevation, back angle recline, again because of his extensor tone, not altering back angle recline, and again a step further than that, if you are concerned about the care plan being followed, is actually locking it away as well. We can disconnect it and hide things. Yeah,
that's what I was going to do. So what we did for Callum was we disconnected, we set up the leg rest, which was just at about 85 to 90 degrees, because we couldn't elevate Callum's legs anymore. So we explained to carers that we're going to set this leg rest, we're going to lock it off.
Yeah.
Seat width adjustment.
And again, for Callum, making that clear, because things do get adjusted. We might need to, especially for hoisting as well, sometimes we need to remove the arms of the chair, so that can help with positioning after hoisting, so we can get that sling out. But then we know that we can use the guide on the chair, you can see there, to put it back to that 400mm for Callum, so that anyone following the care plan knows how to set up the chair.
So what we were looking at there was, bring it close to the screen. You can see we've got measurements here, so we can make sure that the chair is set up evenly with the correct seat width coming from either side of the arm.
And for us as manufacturers, we want to make it simple for clinicians as well, and the support network, and everything that goes into the design of the chairs, with feedback, clinical trials, listening to you out in the field, and getting that response from you, is making sure that we can have confidence that the chair can be used simply, as much tool-free as possible, that care plan can really reflect the measurements and the angles and so on from the setup of the chair.
So the seat width adjustments at the rear, just this little
Seat depth.
seat depth adjustments is at the rear of the chair. If I hold this lever down, and I drag the back towards me, I increase the seat depth. If I push it away from me, I decrease the seat depth. I need to make a note of that seat depth in his care plan as well. Well, I've got the chair this way around. I can show you, you may not be able to see this. There's a serial number on the chair here. The chairs are Class 1 medical devices. So if we needed to check the specification at some point in the future at the review process, we can establish the exact specification of the chair. We've also got a QR code here. So if you're looking at the chair you're visiting Callum for the first time, you're not 100% sure Callum's new to you, scan the QR code and it'll take you to the page on the website that'll give you the full details of the chair.
Yeah, how-to videos and you know, so you can familiarise yourself with the functions. And then my favourite part of the chair, because especially when we talk about safe use of functions and accessories, especially when we think about things like tilt and space with individuals who do have complex needs, is the tilt and space inclinometer. So we can be really prescriptive about how much angle is tolerated. If somebody does have swallow difficulties, or if we work closely with speech and language therapy and we look at meal times, we can be prescriptive in the care plan and keep them as safe as possible within the chair.
Now, the 4-section multi-adjustable back, the adjustment is all tool-free, and you're not going to be able to see this, but the bracketry and the framework of the chair is indented, so we can make a note of where we set each section of the backrest, so that if we come back to review, we can check to see if anybody's altered the backrest configuration and make adjustments if need be. And
this is where photographs are going to be critical as well. So we've got that baseline, and we can compare it to it. But it also helps the support network as well, day to day, to make sure that the chair is set up appropriately for Callum.
Yeah, we can measure back angle recline. We can make a note of that as well. It's little things with the setup. You know, that it's about the detail of the setup, so that it's precise for Callum's needs. Things which may be obvious to us may not be obvious to all. So, for example, making clear that people are aware that the cushion is a pressure care cushion. We don't want to put another cushion on top of this cushion if need be. Perhaps we may need to swap the cushion out, which we can do. So there's a lot of detail that goes into the success of the intervention with a chair.
Yeah, we're essentially writing that care plan so that someone new who doesn't know Callum, who's maybe meeting him for the first time, can pick up that care plan and use the chair safely with him. That's essentially what that care plan is doing. And again, we can support you with that if that need is there.
Yeah, I mean, we often get involved with review of product as well, and then it's where we can check back on the detail of the chair setup to see if things have changed. Some of you may have lost weight. You may be reissuing a chair for an individual, and you may need to establish the possible suitability of a chair for somebody. You can do that from the serial number on the QR code.
Yeah. Just make it very clear in those care plans that there is a point of contact. People don't have to wait for a particular review to happen. If something changes, or if there's an issue, or if there's any concerns or risk factors, then we pass some of that responsibility on as well. As clinicians, we tend to hold that responsibility, but as I said, we're not there 24/7. So we need to pass some of that responsibility on to those who are there supporting someone like Callum daily, and make sure that they know how to then reach out if they need that support.
I think that's it on the chair side of things. Do we have any questions, Kim?
No questions. I've put lots of links in there for any further information that someone might need.
Brilliant. Well, thank you for joining us. So that is kind of a whiz through care plans. We just wanted to give you an idea of the type of thing to include, but really it's going to be tailored to the individual. But we just have to make sure that that care plan can be picked up by someone and they understand that individual, they understand why it's important, and really make it person-centered. So really the compliance is a key part of that.
Yeah, so if there are no further questions, just to let you know, we're also at the OT show in November, so come along and have a chat with us, come along and see the chairs in detail and get hands-on, try the chairs. If there's nothing else, we should say goodbye and catch you soon.
Much.
Thank you. Bye-bye.
Bye.
Bye.